بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا مولانا محمد وعلى آله وصحبه أجمعين. Again to another important item which is abnormal nutrition. We discussed before infant feeding. We discussed before normal nutrition. And I will remind you but some items in the normal nutrition. The diet composed of caloric elements and non-caloric elements of the diet. Do you remember? The caloric needs the diet should be balanced. Our caloric needs should come out 50% from carbohydrate, 35% from fat, and 15% from protein. Our diet should include sufficient amount of vitamins, minerals, and water for the metabolic pathways and for the maintaining the function and integrity of our tissues. What about the abnormal state of malnutrition, abnormal nutrition? How can the nutrition give rise to disorders, diseases? How the nutritional disorders reflected on diseases? It seems logic that when talking about abnormal nutrition, the first thing, overnutrition. Overnutrition will give rise to obesity. Undernutrition, chronic state of undernutrition, give rise to a clinical entity, what's called marasmus. Malnutrition, either malnutrition affecting at the level of the vitamins, give rise to vitamin deficiency, and the commonest one is vitamin D deficiency presented as rickets. Mineral deficiency, and the commonest mineral deficiency worldwide is iron, which is presented clinically as an iron deficiency anemia, or affecting the protein elements and the caloric elements, what's called the protein energy malnutrition, presented clinically as a case of kwashiorkor. Today we will discuss the pure nutritional disorders. We will discuss kwashiorkor and the marasmus. But from this figure, we know that the marasmus is a chronic state of undernutrition. And the kwashiorkor is another state of abnormal nutrition, malnutrition, disturbance of the nutritive elements, disturbance of the nutritive supply. So I have to know the difference between both of them. Before knowing and before discussing the difference between kwashiorkor and the marasmus as a separate entities and a separate diseases, we have to know what about the classification. How are the malnutritions classified? There are four main classifications and all are important. The first classification, what's called the JELIF classification. JELIF classification classified malnutrition according to the clinical presentation. Those who fulfill the criteria and the clinical features of marasmus, known as marasmus. Those who fill the criteria and the clinical picture of kwashiorkor, called the kwashiorkor. Those with flat chest and the flat buttock considered as a mild state of malnutrition. This is according to JELIF classification, only according to the clinical presentations, regardless the age, regardless the weight. Another classification, what's called the Gomez classification. Gomez classified malnutrition according to the weight only, regardless of the clinical presentation. Those above 85% of the expected weight considered as normal. Those from 75 to 85% considered as a mild degree of malnutrition. Those from 60 to 75% considered moderate degree of malnutrition. Those below 60% of expected weight, those considered as have severe malnutrition. Gomez classified malnutrition according to the weight regardless of the clinical presentation. Then the most important classification is Wellcome's classification. Wellcome's make a merge between what's said by JELIF and what's said by Gomez. He classified the malnutrition as shown in the table. First, those who their weight is more than 80% of expected, those are normal individuals. Those which the weight from those with more than 80% of expected, if there is edema, this is considered as nutritional edema. If they don't have edema, this is considered as a normal variant. Individuals with their weight represent about 60 to 80% of expected weight. This is the second part, the second row. If there is edema, this is kwashiorkor. And if there is no edema, this is considered as simple underweight. Those individuals with their weight less than 60% of expected, if there is associated edema, this is considered as marasmic kwashiorkor. If there is no edema, this is considered as marasmus. This is a very important point. So first of all, we have to weight the infant and see what about this weight regarding the expected weight. Is it below 60% of expected? Is it from 60 to 80% of expected? Is it above 80% of expected? If it is below 60% of expected, we are talking about marasmus and the marasmic variants. If there is edema, this is marasmus kwashiorkor. If there is no edema, this is pure marasmus. If the patient is from 60 to 80% of expected with edema, this is kwashiorkor. Without edema, this is considered as simple underweight. Again, welcome the classification, classify the malnutrition according to the clinical presentation, mainly edema, and according to the weight. Another classification is what's called the Waterloo classification. Classified the malnutrition according to the gross charts. Classified into three main parts: wasted, stunted, and stunted. Wasted individual, what's meant by wasted? The reflection mainly on the weight rather than the height. So this patient is expected to have weight for age low, weight for height low, but length or height for age is normal. This is the early malnutrition reflected mainly on the weight. If this malnutrition state prolonged, this will be reflected also on the length, and so the patient will be changed to another category, what's called the stunted. So what about the stunted? Stunted individuals, those who are, the weight is affected and the length is affected. Usually the weight and length is affected nearly equal. So the weight for age is low, the length for age is low, so the weight is affected and the length is affected, but the weight for length is normal because both of them nearly affected equally. Another classification, those who are wasted and stunted, all parameters are affected and undisturbed. So the weight for age is low, the length for age is low, and the weight for length is low. So this slide representing the main classification for the malnutrition. Remember again, the previous slide, obesity will be discussed elsewhere. Vitamin deficiency will be discussed elsewhere. Mineral deficiency will be discussed elsewhere. Today we are going to discuss the pure nutritional disorders, disturbance, mainly kwashiorkor, marasmus, and the marasmic kwashiorkor. And these are the classification to support this disturbance. Back again to the main two diseases we are discussing now, kwashiorkor and marasmus. Keeping in mind, kwashiorkor patient, his weight from 60 to 80% of expected and associated with edema. This is according, welcomes the classification. The marasmic patient, his weight is less than 60% of expected, but without edema. Now the situation, what about the kwashiorkor and the marasmus? What are the disturbance? What is the nutritional element disturbed? For kwashiorkor, the main problem is that there is protein deficiency and the caloric excess. For marasmus, there is protein deficiency and the caloric deficiency. This is the mainstay of the disease. This is the main problem of the disease. So now the question is, how come the protein is low and the carbohydrate is high and the calories is high? We can use this. If this infant is breastfed infant, breastfeeding can give rise to kwashiorkor and can give rise to marasmus? Yes. How breastfeeding can give rise to both? Breastfeeding, if the breastfeeding was prolonged breastfeeding without supplementation, what does it mean? Means low protein, low calories, and the needs increased by age. This is prolonged breastfeeding without supplementations. So it will give rise to marasmic and marasmic disorders. The prolonged breastfeeding and supplemented by sweetened fluid, this will make a disturbance called kwashiorkor. So prolonged breastfeeding, there is deficient protein and deficient calories. These calories are compensated for by the sweetened fluid. So this patient have protein deficiency and the caloric excess. This is the kwashiorkor. Again, the infant, artificially fed infant. How artificial feeding can give rise to marasmus or kwashiorkor? Artificial feeding, if it is diluted, unsweetened feeding, this will give rise to marasmus. Diluted feeding and unsweetened, so caloric less and protein less. But diluted formula and sweetened, this will give rise to low protein and high calories, a clinical entity caused as kwashiorkor. What about those who are weaned? We discussed those who's breastfeeding, how the breastfeeding may give rise to either disorders, and artificial feeding, how artificial feeding give rise either disorders. What about weaning? The weaned infant, if there is no or less diet, less protein and less calories, will give rise to marasmus. If there is less protein intake but high carbohydrate intake, sweetened fluid, sweetened juice will give rise to kwashiorkor. So the breastfed infant, yes, can give rise to marasmus or kwashiorkor if it is prolonged, and it depends about the supplementation. The artificial fed infant may give rise to marasmus and the kwashiorkor. So it is very important for nutritional history and dietetic history to inquire about the breastfeeding, the full history of the breastfeeding, and the full history of artificial feeding. Only to say this infant is a breastfed infant, this is deficient history. You have to take a full history. This infant is a breastfed infant. 1 or 2 breasts at a time. For how many minutes? How many times per day? Are there satisfaction or not? Remember, the criteria of satisfaction including proper increase in the weight, sleep after feeding, good urine flow, and the good bowel habits. What about artificially fed infant? You have to know this infant is artificially fed infant. This is not the only thing. I have to have details. What about the artificially fed infant? What is the formula? This infant is artificially fed infant. For example, X formula. How it is prepared? I should know how many ml water should be given to the baby and how many milk powder given over this amount of water. For how many times per day, and is there satisfaction or not? This is an important point. For example, if I am using a formula like Similac, for example, I know that each scoop is sufficient for 60 ml water. If the mother told me that I usually use 120 ml water and add only 1 scoop of Similac, this is diluted formula. If the patient is dependent on such a formula, will give rise to marasmus. If the mother say the same scenario, this is 120 ml water and I add 1 scoop of Similac and I add one spoonful of sugar, this is diluted and sweetened formula. This will give rise to kwashiorkor. This is very important. So learning the mother about the breastfeeding and the weaning practice and the artificial feeding, how to prepare the formula. What about the signs of satisfaction, the symptoms of satisfaction? This is a very important issue, especially for us as a pediatrician. So now we know how kwashiorkor, how the feeding gives rise to kwashiorkor, how the feeding pattern gives rise to marasmus. And now the question is, what about the clinical features of kwashiorkor and the clinical features of marasmus? The clinical features of kwashiorkor, there are constant features and variable features. The constant features are 4 in number. You have to know. The first thing, edema. And this is important, and we will discuss it in 1 minute. The second one is mental retardation. Why mental retardation? Because the chemical transmitters in the brain, mainly protein in nature. So the connections between the brain sites and the cells and the behavioral changes occur later on, and the patient will be mentally subnormal because they have protein deficiency, which is a very important issue. The patient has gross failure. This is for sure, because the kwashiorkor patient, his expected weight is from 60 to 80%. His weight is 60 to 80% of the expected weight. And this weight, why it is usually more than the weight, the expected weight for marasmus? Because this is the weight of edema. And the fourth thing, there is decreased muscle fat ratio. What's meant by this? The patient have low protein, so the muscle bulk is less. And the high calories, so the fat content is more. So the muscle fat ratio is disturbed, it is low. On the other side, what about the constant features in the marasmus? The marasmus does not have edema. Instead of this, they have wrinkled skin due to loss of subcutaneous fat. Loss of subcutaneous fat, why? Because the patient have deficient calories and deficient protein. Deficient calories, so he consumed his fat. So the patient have deficient fat, low fat. Absence of fat from the abdomen, this is considered at the first degree marasmus. Absence of fat from the buttock, this is the second degree marasmus. Lastly, absence of fat from the buccal bed of fat, which gave rise to senile facies or old man facies. This is the third degree marasmus and the severest form of marasmus. Back again to the kwashiorkor. What about the edema? The edema, the mechanism of edema is, you have to know such a mechanism. It is a simple mechanism. It is related to the capillary circulation. You know that at the arteriolar end of the capillaries, there are 2 forces against each other. The first force is the hydrostatic pressure, tend to force fluid outside the capillaries. And the second antagonizing force is the osmotic pressure of the plasma protein. At the arteriolar end of the capillaries, the hydrostatic pressure is the dominant. So the fluid is poured outside the capillaries and get in contact with the cells. The reverse occurs at the venular end of the capillaries. There are the same 2 forces, but the hydrostatic pressure is low and the osmotic pressure of the plasma is higher now. So it will absorb these fluids again. This is the capillary circulation, the normal capillary circulation. What about these circulations on the view of protein deficiency? At the arterial end of the capillaries, the hydrostatic pressure is still higher, pouring the fluid outside. And at the venular end of the capillaries, who is gonna absorb this fluid? The osmotic pressure of the plasma protein, which is deficient. So the fluid poured outside the capillaries will remain there, give rise to a picture of edema. This is an important issue. Another questions will be raised up to be shared with you. Why the patient with kwashiorkor have edema and the patient with MARAS has no edema, in spite of both have protein deficiency? As we said before, kwashiorkor, protein deficiency and the caloric excess. And the marasmus, protein deficiency and the caloric deficiency. And the main mechanism of edema is due to protein deficiency. So why kwashiorkor has an edema, but marasmus has no edema? Instead, he has wrinkling of the skin. For sure, marasmus also have growth retardation and mental retardation because it has also protein deficiency, and the muscle wasting are there. Again, the clinical features, this is important to know. The kwashiorkor and the MARAS have constant features. But what about the variable features? Variable features, it is variable. It depends on the severity. It depends on the baseline of the organs affected by the variable features. The first and the important variable features is skin changes and hair changes. Hair changes, for hair we have to know general idea. For hair, for the strength of hair, we need sulfur containing amino acids. This number one. For the density of hair, we need zinc. For the shiny hair, we need a copper. Those elements are usually deficient in kwashiorkor and in marasmic patients. So what? So the hair is sparse, easily pickable, is light hair, it is less dense. This is because deficiency of sulfur containing amino acids, deficiency of zinc, and deficiency of copper. These hair changes depend on the situation. So the hair now, light in color, easily pickable, brittle. Now, if the nutritional status of the individual improved after that, so the coming part of the hair is good. If the nutritional status disturbed after that, so the coming part of the hair is disturbed. So we have to find the hair, one part is good, shiny, and the other part is light. Shiny, light. This is what's called the flag sign. So what is the flag sign? These are the hair changes, normal hair alternating with abnormal hair. Normal, abnormal, normal, abnormal. And what does it reflect? It reflects that normal and abnormal states of malnutrition. Normal and abnormal periods of malnutrition. But what about the skin changes? The skin changes usually in the perineal area and the buttock area. Skin changes are dark devitalized areas alternating with normal areas. After that, these dark devitalized areas will give rise to ulcers. The picture of dark areas in between with hypopigmented areas will give rise to a picture what's called copylestone appearance. These are an important features you have to know. And there are also variable features. Those patients, whether kwashiorkor or marasmus, have different forms of anemias. Have hypochromic microcytic anemias? Yes, because of iron deficiency. Have normochromic normocytic anemias? Yes, because of chronic infections. May have hyperchromic macrocytic anemias? Yes, because B12 and folic acid deficiency. All forms of anemias are there. Those patients have GIT changes? Yes, the GIT system is one of the first systems to be affected by this malnutritional status. The GIT system is dependent mainly on the protein, dependent mainly on the calories, because it is working most of the time. Deficiency of the enzymes, deficiency of immunoglobulins will give rise to malabsorption, loose stool, will give rise to constipation, starvation, diarrhea, will give rise to infections later on, and this is a very important issue. The main cause of death of such individuals is either infections, especially bronchopneumonia, due to deficiency of immunoglobulins, and dehydration due to loss of intake and due to diarrhea. These are examples for the variable features. So back again, kwashiorkor, protein deficiency, caloric excess, constant features, edema is the salient features. Variable features may be there and maybe not. It depends on the severity. Marasmic, protein less, calories less. Constant features, no edema. Instead, there is wrinkling of the skin. loss of subcutaneous fat. And we classified the degrees according to the site of the subcutaneous fat loss. Variable features is still there. What about the lab findings? It is expected for such individual to have disturbance of the lab findings. If we are talking about the protein, it is expected to have plasma protein low, total protein low, plasma protein low, blood glucose may be low in the marasmus, but usually it is high in kwashiorkor. Remember, marasmus has low calories, but kwashiorkor has high calories. This infant may have infections. This may be reflected on the CBC. This infant may have anemia. This may be reflected on the CBC. So a list of investigations are there to prove that this infant has deficiency in many areas, in many aspects. And we have to investigate for the underlying cause. Is the problem for kwashiorkor and the marasmus related only for nutritional intake? No. There are some disorders, some diseases which may give rise to marasmus and the kwashiorkor. Simply parasitic infestations. Back again to the previous slide. So causes. There are secondary causes. What's called the secondary causes? For kwashiorkor, gastroenteritis, especially infestations, parasitic infestations, measles and whooping cough. Why measles and whooping cough in particular we use to describe as the cause of kwashiorkor? Because measles is a debilitating disease. The patient have high fever. Patient may have vomiting, may have diarrhea. And before, there were what's called faulty restriction of food intake in the patients with measles. And this is fault. Nowadays, it is changed. This behavior is changed. What about whooping cough? Whooping cough is another important issue because the patients have bouts of cough followed by vomiting. And these bouts of cough usually initiated by feeding. So the patients, when start to feed, he cough and vomit. Instead of getting sufficient calories and sufficient elements, no, he does not, and evenly he vomit. So this patient is more liable for dehydration and more liable for deficiency. For marasmus, many systems may be involved with any congenital anomalies or chronic problems in most of the systems for long period will give rise to a marasmic picture. And the main system is the GIT because this is the system involved mainly to give the body, to supply the body with nutritional elements. If there is congenital anomalies in the GIT or chronic problems of the GIT, it's supposed to give rise to marasmus. Patient with celiac disease, with the inflammatory bowel disease, patient with malabsorption, patient with obstructive lesions in the GIT, etc. And the same situations regarding other systems. That's what's called the failure to thrive or the secondary form of failure to thrive. The most important issue, now we diagnose the malnutritional status, either kwashiorkor or marasmus, depending on the clinical presentation, using mainly edema and the weight, according to Wellcome's classification, as you remember. What about the management? How to deal with such a case? For the management, you have to remember 4x4. This is an important issue. What's 4x4? The first thing, I have 4 emergency measures I have to take. What are these 4 emergency measures and when it should be used? Blood transfusion. If you have an infant severely malnourished, severe vitamin deficiency, severe mineral deficiency, severe infections, bleeding elsewhere in the body, bleeding may occur in the malnutritional status? Yes, for sure. This infant with these diverse disorders, the only thing will improve him is the blood transfusion. The blood transfusion is the cornerstone for the treatment. It will provide him with hemoglobin, RBCs, correct anemia, with white blood cells to correct infections, with the platelets to control bleeding, with immunological factors, with plasma to correct dehydration. So blood transfusion is considered in the severely malnourished individual. This number 1. If the patient is dehydrated, you have to treat dehydration first, because this is the second most common cause of death after bronchopneumonia. Remember, you have to assess the infant, infected or not. I have to treat infection. I have to treat and correct dehydration. The third one, electrolyte disturbance. This infant is expected to have an electrolyte disturbance. So I have to do U&E and correct the electrolyte disturbance. If there's hyponatremia, correct it. Hypokalemia, hypophosphatemia, hypocalcemia, hypomagnesemia, we can correct it first. This is before the nutritional improvement, the nutritional correction, or the nutritional rehabilitation. And those patients usually have hypothermia, especially the marasmic patients. We have loss of subcutaneous tissues, loss of subcutaneous fat. So this hypothermia is another important point to be fixed first. because this will give burden on the caloric needs, and this will give burden for the other metabolic pathways. This is the first one in the 4. Remember, management of protein energy malnutrition is 4 by 4. 4 items, and each item has 4 sub-items. What are the 4 items? Number 1, emergency measures. Number 2, preventive measures. Number 3, specific measures or specific management. Number 4, recovery criteria. And each item of these 4 have 4 sub-items. We discussed now the emergency measure. What about the preventive measures? To prevent these malnutritions, it should be prevented at the family level, then at the community level, at the nation level, and at the world level. At the family level, we have to encourage breastfeeding. We have to educate the mother about the weaning practice, about how to prepare the artificial formula, about the disorders which may give rise to protein energy malnutrition. This is an important issue, and this is our rule, individual by individual, face to face, one to one. We can prevent this also at the community level, increasing socioeconomic standard and socioeconomic levels, and at the nation level for health educations and health promotions, and also at the worldwide level for general health education and general health promotion, and we can utilize the media in such aspects. Every mother should know everything about the nutritional status of her individual, how to provide proper nutrition, how to provide breastfeeding, what is the advantage of breastfeeding, what is the advantage of artificial feeding, when to use, how can we use it, what are the criteria of satisfaction, how to use the food stuff and the food items. This is the preventive measures. This is the second items. So it is also at the 4 sub levels. What about the third level, the main line of treatment? This patient, as I said to you, we are discussing here only kwashiorkor and the marasmus. The main problem of kwashiorkor, again and again and again, it is protein deficiency and the caloric excess. For marasmus, it is protein deficiency and the caloric deficiency. So when I'm going to fix this problem, how can I fix it? For the kwashiorkor, we don't need more calories. So those patients will give him less than 90 calories per kg per day. But we will give him protein more. For marasmus, the idea is to give him more calories and more protein. So for marasmic patients, we have to increase the caloric needs up to 150 calories per kg per day, even up to 200 calories per kg per day. These are very important. I will give him the calories and I will supplement him with protein excess. How can we give this? Either if the infant is breastfed infant through breastfeeding, formula fed infant, adjust the formula fed, or the weaned infant, we adjust the food intake to support these 2 deficient elements. This should be given every 2 hours, round the clockwise, and either should be given by bottle or by a spoon or any other method. This to fix the problem there in the kwashiorkor and the marasmus. Another important point, we still in the third item, in the dietetic measures, in the dietetic treatment. This is the main items of treatment. But I may need a non-dietetic element to support. I may need blood transfusion, may need plasma transfusion, I may need albumin or amino acids. We may need adjuvant therapy, tonics, fluids, vitamins, anabolic or prophylactic antibiotics may be needed to support according to the situation. Important issue, and the last thing, during nutritional rehabilitation, we don't like to rush to the full correction rapidly, because this may give rise to certain disorders. And there are 4 main criteria during recovery, 4 main disorders during recovery. You should be aware about it. The first thing, what's called the nutritional recovery syndrome. What's meant by nutritional recovery syndrome? The patients, especially the kwashiorkor patients, have a lot of fat and there is fatty liver. When we are trying to fix the problem and giving the patients protein, sufficient protein and average amount of calories, the liver store glycogen before getting rid of the fat. So there is more hepatomegaly and more liver enlargement. Don't worry. This is a normal process. Go on. This is the first thing. And the other thing is what's called CAN syndrome. If the patient were given a large amount of protein, excessive amount of calories, they may give rise to neurological manifestations. And neurological manifestation more or less similar to Parkinsonism, what's called the Parkinsonian-like features, rigidity, tremors, etc. While we are correcting these patients, do you remember in the first column, we have to correct the dehydration if there. there is some errors. Maybe the patient may be overhydrated, or there is maybe an electrolyte disturbance. For a reason or another, those patients with marasmus and the kwashiorkor may develop what's called the pseudotumor cerebri during recovery of unknown cause. Pseudotumor cerebri is represented by benign increased intracranial tension, but don't worry about this. This is a benign condition. Go on for the management and go on for your dietetic and non-dietetic treatment. Again, these patients, you have to be wise for correcting and to fixing this problem. To be wise, and the question is, if I'm going to fix the problem of marasmus and the kwashiorkor, I'll give him, for example, for marasmus, I'll give 150 calories per kg. And the question is, which kg? Is it the actual weight? Is it the expected weight? Is it the average weight between the actual and the expected? Some schools may go with the average weight and increasing gradually till the expected weight. But it is wise to start with the calories and the protein and the carbohydrate and the fat requirements according to the actual weight, and increasing it gradually to meet the average weight, and increase it gradually to be those for the expected weight, in order to lessen the complications and in order to bust safely the nutritional recovery rehabilitation disorders. These are the recovery criteria should be kept in mind while treating such disorders. As before, we have some questions to share their answers. Please share the answers with me through the link on the YouTube or directly through the email listed below. The first question, marasmus, unlikely kwashiorkor, has no edema in spite of hypoproteinemia present in both conditions. We raised up this question during the presentation, but the answer is still, we are waiting for you. The second question, hair changes are less likely in marasmus than kwashiorkor. Why? Both have the same disorders nearly. And the third questions, this is the questions we have answered during the presentation. At which weight one should calculate the caloric treatment for the malnutrition? Is it the actual weight? Is it the expected weight? Is it the average weight? And the fourth one, what is the over-energetic nutritional rehabilitation? The fifth one, how marasmus changed into kwashiorkor and the vice versa. Marasmic patients change it to be kwashiorkor. Kwashiorkor patient change it to be marasmus. How come? How this interchangeary pattern occurred? And the last one, what is the nutritional recovery syndrome? And does it need any management? Should we stop the dietetic and non-dietetic measures upon this nutritional recovery syndrome or not? Please remember that we have a case scenario. We gave it before in the normal nutrition. Keep the answers and the discussions together through the email or through the YouTube link. Thank you very much.